So Zach,
Hello.
y'all ready to go today?
Yep, sure am. Should I start whenever?
Yeah, I think Dr. Heflinger and Dr. Erashenko are here. So can you tell us about this new cool antibiotic?
Yeah. So, hello everybody. I'm Zach, and I am very excited to be here talking about this antibiotic that I feel like is very underutilized, and not enough people know about it. And so I'm here to kind of shed some light on that. So my discussion topic question is, does Xerava play a role in antibacterial stewardship with regard to the emerging prevalence of carbapenem-resistant organisms? So I have an outline for you here. We're going to go through objectives, introduction, my PICO summary. We're going to look at some in vitro data. And then after that, we'll move along to some human subject data that was published called Ignite 1 and Ignite 4. I want to discuss its potential place in therapy. We'll go over conclusion, and then we'll have a discussion at the end. So my objectives are to appreciate the importance of discovering new antibiotics to combat the emerging pathogens that are becoming increasingly resistant to carbapenems. Recognize how in vitro results extrapolate to real-world potential for eravacycline to treat many bacterial threats that the CDC and the WHO have deemed as urgent or critical priorities. I'll explain the human trials that demonstrate eravacycline non-inferiority to carbapenems in complicated intra-abdominal infections. We'll then compare the cost of eravacycline to comparator agents, and we'll do that from the perspective of the patients as well as health systems. And then I'll illustrate the role our eravacycline may have in future stewardship practices. So as far as a background for carbapenem goes, there's pretty high resistance rates across the world. For Europe, ESBL, or extended spectrum beta lactamase producing E. coli strains, are at about 15%. They also see Club pneumo at about 30%. North America, fortunately, it's lower here. ESBL, E. coli, is about 10%, as well as Club pneumo. But then when you look at Southeast and East Asia and China, they have some pretty crazy resistance rates for E. coli that jump from 40 up to 70%. And that's pretty scary, especially since carbapenems are considered a last line of defense. And due to a rapidly rising number of clinical infections that are the result of carbapenemase producing pathogens, we need something else. And those resistance mechanisms are many times due to clonal expansion, transfer of genes, and many of the Enterococcus and Acinetobacter baumannii, which we'll discuss more as we get through this presentation, they're often multi-drug resistant. And so due to this, we need something that is a last line, I guess you could say, if carbapenems are not going to be effective anymore. So this slide here, if you look at the image, this is, if you can read that, I know it's small print, but if you can see what's going on here, this is really highlighting geographical regions across the world and their respective resistance and type of mechanisms. Honestly, we could spend an entire seminar or more going over the mechanisms, but just to kind of summarize and highlight some of them, you've got carbapenemases. And when you see the acronyms there, KPC, IMI, that's saying Club pneumo carbapenemase, imipenem resistance, oxacillin, and then NDM is actually it's a really big one, but it was discovered in New Delhi, so they decided to call it the New Delhi metallo-beta lactamase. Mobile genetic elements are another form of mechanism with integrons TN4401, other metallo-beta lactamases, ESBLs, cephalosporinases, and multi-drug resistance. And many times that's due to fluoroquinolones, as I'm sure many people understand that concept. And once again, with that image, I just want you to not take it as entirely factual. I just kind of grabbed that from the internet. I don't know if it perfectly shows the resistance rates, but from my research, it seems accurate enough to highlight those emergent regions. So when we look at the CDC, they publish, I don't know if it's every 2 years, an antibiotic resistance threat report. But what I'm trying to get at here is that there are some urgent threats, and then the next level down is serious threats. When you look at these bacterial pathogens, you can notice that there's an arrow next to each one. That's kind of the trend that we've been seeing since 2017. So one arrow indicates that there's a slight decrease or maybe leveling out. If you see 2 arrows going up, as in the ESBLs, you're seeing a very high increase in prevalence. But what you should keep in mind here is in the orange, I have showed the estimated cost that the CDC is saying that is an annual cost for each of those individual pathogens. And these are things like how much the drug costs. This is rehospitalization rates that hospitals don't get reimbursed for. There's a multitude of reasons. So going through that list, carbapenem resistant Acinetobacter is an urgent threat. C. diff is a major urgent threat. CRE, or carbapenem resistant Enterobacteriaceae, so that would be like E. coli. And then serious threats, we've got the ESBLs, vancomycin resistant enterococci, and then MRSA. One thing also to keep in mind as we go through this presentation with C. diff, we know that it's known to be induced by many of the antibiotics that we are using to treat other infections, and that could be fluoroquinolones, cephalosporins, ampicillin, even carbapenems. So we get to a point where we use these great antibiotics, including carbapenems, but if C. diff is a result, it's kind of hard to avoid those drugs and try to limit C. diff as well. So all those costs together, I did a quick little calculation, and it comes to about $5 billion. And that's pretty insane. It's honestly projected to increase due to a lot of those resistant pathogens coming from East Asia and China, making their way through Europe and then to North America. I don't have any specific data on those projections, but that seems to be the trend in how pathogens work. Eventually, they'll come over here to North America. So that leads us to my topic today. What is eravacycline, or brand name Xerava? It's a tetracycline. It's a little bit different than the other ones. It's the first fully synthetic fluorocycline antibacterial. If you look on the Xerava picture here that I took from their website, you can see fluorinated at the C9 and then the C7. They've got a little bit different structure here in comparison to tigecycline, which we'll get into tigecycline. It's actually a very good antibiotic to use when you are seeing carbapenem resistance. They work pretty similarly. But one thing that the C7 and the C9 substitutions have is that they block the tetracycline specific resistance mechanisms that you see with tigecycline and minocycline, and those are efflux mediated and ribosomal protection. And on the right, I first want to show, this is the WHO. This is essentially the same thing that the CDC reports. And they use different verbiage. Instead of urgent, they use critical. Instead of serious, they use high. You see Acinetobacter baumannii, that's carbapenem resistant. Enterobacteriaceae, that's carbapenem and cephalosporin resistant, and those are some major threats, as well as Pseudomonas. And when you look at the package insert for ravacycline, you see that it's indicated only for the treatment of complicated intra-abdominal infections. And those are organisms susceptible to ravacycline, such as E. coli, Klebpneumo, Enterococcus. And you can see that these are all things that the CDC and the WHO are seeing as a priority. One thing that's not on there, though, is they don't mention that they can treat C. diff. And so part of this presentation is to shed light on should that be in the package insert. So we'll move along to my PICO summary. How I formulated the PICO question, the problem, as you've already seen, I'm sure, is that there's rising concern in the emergence of bacteria expressing resistance to carbapenems through ESBLs, cephalosporinases, carbapenemases, MDRs, and carbapenems are considered last line. And so we need something after carbapenems are no longer effective. My intervention is a ravacycline, only as IV. Comparator is all of the current therapies that are indicated for use in specifically complicated intra-abdominal infections, just because the research that's published and honestly what it's indicated for, I had to kind of limit it there. But this is due to carbapenem-resistant Enterobacteriaceae, all of those scary pathogens that you see there. Outcomes that I looked at were infection rate, or infection cure rate, sorry, side effect profile, mortality, morbidity, cost to the patient and healthcare system, and then a potential role in stewardship. My lit search was not just limited to PubMed, but on PubMed, I looked up ravacycline, CRE, agents that were comparable to ravacycline, and then the organisms that I wanted to know more about and how effective ravacycline was at treating. So Acinetobacter baumannii, E. coli, Klebpneumo. Tried to find some meta-analyses. It's a fairly new drug, so there's not a lot of the analyses that you find out there are actually just comparing the IGNITE trials, which aren't extremely helpful. And there's not really much meta-analysis out there. And I also wanted to try and discuss about ravacycline and complicated urinary tract infections. And so I tried to find some information on that. Oh, we'll discuss that later. I didn't use any filters. Honestly, it was approved in 2018. It's a fairly new drug, so I took all the information that I could get. As far as my non-pub materials, I used the references from my in vitro studies and the IGNITE trials to get a lot of good information. And honestly, I think I backtracked with those references and got more material than actually going through PubMed. I also used Xerava.com and tphase.com, which is for tetraphase. Tetraphase is the company that produced this. They've now merged with La Jolla Pharmaceutical Company. My summary table here, you can see the first 3 studies are the in vitro studies that we're going to look at momentarily. The 4th and 5th are the IGNITE trials. You can kind of read through that and see the design, the population, the ICO, and my assessment. But why did I include these studies? So for the first one, I wanted to look at Acinetobacter baumannii. It's been here in America for a while now, notably seen in outbreaks in Vegas. Resistance rates are almost astronomical in eastern parts of the world. And so I wanted to see the potential of ravacycline to treat that. The second study focuses on E. coli and those multi-drug resistant strains that are appearing. This study actually was very good at, if you look here in the comparator, you can read all of these different antibiotic agents. So it compared the susceptibilities of a myriad of current therapies to ravacycline in a very reasonable way to judge this new drug's real world efficacy. So we'll see that soon. My third one was looking at C. diff. And many, as I mentioned before, many of the heavy hitter antibiotics that are used to treat the worst bacterial infections can actually induce C. diff infections. And additionally, C. diff is also showing increased resistance to many of the mainstay treatments like Vanco and fidaxomicin. So eventually we're going to need something else for C. diff. Ignite-1 was the first study that proved that eravacycline was non-inferior to ertapenem. So that's a no-brainer. That one had to be discussed here. Then Ignite-4 was essentially the same type of study, but it looked at another carbapenem. So I think they were trying to drive home the notion that eravacycline really does work in complicated intra-abdominal infections, as well as to gain some extra clinical data. So moving along, we'll look at the in vitro data, and I wanted to include this as a warm-up to the human subject data to highlight its potential against some of the most concerning pathogens we're seeing right now. So what's with the crabs in turkey? CRAB stands for carbapenem-resistant Acinetobacter baumannii. This was declared urgent and critical, as discussed previously, by the CDC and the WHO. And the way they built this study is they were looking at a synergistic effect between eravacycline and colistin. Colistin is, from my understanding, it's like a salvage therapy for carbapenem resistance. Its mechanism of action is it's a prodrug as cholestymiphate that turns into colistin in your body, and it works as like a detergent that breaks down the membrane on the bacteria. And so they know this one works pretty good. They wanted to see if eravacycline worked as well, or if it helped create a synergistic attack on bacteria when combined. So what they see, this table I made here is MIC data, and obviously lower the better. You can see in all of those 10 isolates, eravacycline consistently inhibited growth, way more so than meropenem. And colistin, it was 50% on par with it, and 50% of the time it beat it in the MIC inhibition. And over on the left, these are some really scary numbers. In Asia, they are seeing 50% of strains that are collected and reported to be resistant to meropenem and or colistin. And this is just in general. This isn't just the isolates that they were looking at. So that's a pretty unbelievable number. In Eastern Europe, they are seeing up to, and sometimes exceeding in some places, 90% resistance to meropenem and colistin. And this is the scariest one in Turkey, the crabs in Turkey. According to the National Health Statistics, 91 to 98% are resistant. So we need something else. When we look at E. coli, this data is from the March 2018 issue from the Journal of Antimicrobial Chemotherapy. And you can see the susceptibility of eravacycline is extremely high, right up there with tigecycline. Its inhibition profile seems to be slightly better, definitely more so than many of the cephalosporins and carbapenems there. Ertapenem is not a good option at all, if you can see me highlighting right here. But I really like the quote that came from this study, because this really resonates with my thought on this. They said that multi-drug resistant E. coli subsets threaten the utility of carbapenems as reliable fallback agents for infections due to organisms resistant to ESBL, cephalosporins, and fluoroquinolones. The high percentage of isolates susceptible to eravacycline supports the presumptive use of eravacycline against carbapenem-resistant E. coli isolates. And this is the important takeaway here that we'll see later. Decisions regarding use will be influenced by such factors as cost, type of infection, and drug allergies. And really, these are all things that we should keep in mind anytime we're recommending a drug therapy for a patient. But cost, type of infection, and allergies, very important. This next one here is a poster presentation that was done in 2019 by Kevin Gary. He's a PharmD professor and chair at their College of Pharmacy there. And when I saw this data, I thought it was too good to be true. It probably isn't something reliable. And so I researched Kevin Gary, and he's very big in the infectious disease community, gives lots of presentations, many publications, and that really helped solidify the legitimacy of this. But if you look at the data in bold, it shows eravacycline, the MIC 50 and 90. There's a few instances, I think this third one here, fidaxomicin, was more potent than eravacycline. And I think this last one as well, fidaxomicin was more potent than eravacycline. But they did this other MIC determination. It's a geometric mean. And from my understanding, the way that is they take from MIC 0 all the way to 100 and make almost a scale of the MIC to determine how effective it really is. And it had the lowest or most potent MIC all across those variations from 0 to 100% inhibition. And I think that's an important way to look at this. But his conclusions were that eravacycline is promising for the treatment of C. diff. And one thing too I didn't mention with this, these ribotypes over here, they're not just randomly picked ribotypes of C. diff. These are the known most resistant isotypes for sorry, I got a text message. These ribotypes are the ones that are causing trouble for fidaxomicin and vancomycin for resistance purposes. One thing to keep in mind here is eravacycline works as the normal tetracycline mechanism of binding to the 30S ribosomal subunit, so it inhibits bacterial protein synthesis. When you look at fidaxomicin, it's actually bactericidal. And so honestly, it would be good to see real world data, if that changes how effective eravacycline is. But as of now, it seems like it's a really good option. So we'll move into the main subject data. Ignite 1 trial is called Assessing the Efficacy and Safety of Eravacycline versus Ertapenem in Complicated Intra-Abdominal Infections in the Investigating Gram-Negative Infections Treated with Eravacycline. This design was a phase 3 randomized double-blind multi-center study. It had 66 clinical sites in 11 countries. Its main purpose was to evaluate the safety and efficacy compared to ertapenem only in patients with complicated intra-abdominal infections that required surgical or percutaneous intervention. They did a test of cure evaluation at 25 to 31 days after the first dose, and they did a follow-up visit 38 to 50 days later. They had 541 patients that were randomly assigned and stratified based on primary site of infection. 270 received eravacycline, 1 mg per kg, Q12, and 271 received ertapenem, 1 gram, Q24. They required a minimum of 4 24-hour dosing cycles I think some of them even went up to about 14 days. And the mean ages were 55 years, and it was about 95% white male. So it's pretty heavy on that ethnic background. Inclusion criteria: patients had to be hospitalized for intra-abdominal infections requiring intervention. They had to be 18 years or older. They had to have evidence of systemic inflammatory response. They had to have pain caused by the infection. They had to be able to provide informed consent. And they had to confirm diagnosis of intra-abdominal infection with sonogram or radiographic imaging or visual confirmation. For eligibility of exclusion criteria, if there was a rapidly progressing disease or immediately life-threatening illness, such as hepatic failure, they didn't let them participate. And if you look at this about fifth one here, if the anticipated survival period was shorter than the study period. So essentially they're trying to throw out any anomalies that could occur from somebody not being able to finish the treatment or have some sort of other life-threatening illness that would require them to use other antibiotics. They also didn't look at creatinine clearance less than 50 mils per minute. And as far as appendicitis goes, if they had symptoms related to a complicated appendicitis for less than 24 hours prior to this hospitalization, they were also excluded. Okay, some of the definitions here. The primary outcomes are going to be safety and efficacy compared to ertapenem, but the secondary outcomes are going to be clinical cure, clinical failure, and then indeterminate and missing. So clinical cure essentially means, and this is straight from supplementary material from Ignite 1, but it means complete resolution or significant improvement of signs and symptoms of the infection such that no additional antibacterial therapy, surgical or radiological intervention was required. Failure means there was death related to the infection anytime, persistence of clinical signs and symptoms, unplanned surgical procedures, or any additional antibiotic drug therapy during that time. Missing, this one kind of was funny to me that they included this in here, but I guess larger studies like this, they have to account for some small percentage of not getting data. And so missing is defined as investigator did not complete an assessment or if the patient wasn't present for test of cure study visit, which you could almost interpret that as if the patient doesn't show up and they're not dead, they must be cured. But if they don't have the data, they can't include it. Analysis, their primary efficacy endpoint was clinical response at the test of cure visit in the microbiological intent to treat population for the FDA, and in the modified intent to treat and clinically evaluable populations for the EMA, or the European Medical or Medicines Agency. To satisfy the FDA, they used a non-inferiority margin of 10%, and it was based on the lower limit of the two-sided 95% confidence interval. They did a review of source control for those patients whose clinical outcomes were considered failure. And honestly, this was almost an above and beyond thing that they did, because if a patient did not recover either on ertapenem or eravacycline, and they deemed that it was because of poor source control initially, then this is something that they could, create accountability for the hospital or surgery team to say that they missed out on something to help this patient. For their results, on the right side, you'll see an orange underline. If that number is -10 or greater, that means, or closer to 0, then that means that they achieved the endpoint they were looking for. So in this instance, all different population that they looked at met the criteria for non-inferiority to satisfy the FDA as well as the EMA. So the other primary outcome they were looking at was safety. And this is pretty interesting. If you look at the total adverse drug reactions here, you'll see ribociclib at 42% is higher than the ertapenem at 28. And when you look down here at nausea, you'll see that it's significantly higher for ribociclib, 8% versus less than 1. Injection site phlebitis is 3 versus 0.4%. They're not huge numbers, but they are significantly more than the carbapenem, and so it's something to just remember. However, when you're looking at really life-threatening and fatal events, they're really on par. You see about 5% here, about 6% here. And as far as deaths go, there were 9 in the study. There were 3 from ribociclib and 6 from ertapenem. And you can see, you can read the specific causes there, pulmonary embolism, respiratory failure, but none of those were considered related to drug therapy. And so we don't have to worry about it being not safe for the patient, except for nausea and phlebitis. Strengths and weaknesses. One of the strengths was they limited the percentage of patients with appendicitis to 30%. A lot of the trials for Zerbaxa and Abicaz, which are competitors to Xerava, they actually allowed 46 and 41% of patients to have appendicitis, respectively. And honestly, there's a high cure rate with appendicitis, and so it skews your numbers. So it's good that they limited it. Documentation of the organ of origin rather than only the presence of the abscess or peritonitis. And this dictates the type of procedure performed to provide adequate source control. So therefore, the documentation corrects any underlying intestinal discontinuity and infection cure. They excluded patients with rapidly fatal illness or septic shock, and that's good because you don't want the patients that are going to have other issues. You want to actually just test the efficacy of the study drug. Weaknesses, they couldn't adequately control for confounding variables such as premorbid conditions, details of the acute disease process, or standardized perioperative care practices, because it was from 66 different sites. There's an inherent ethnicity bias, but you can't really get around that. It's really kind of what the patient profile was. And so it'd be good to see other ethnic groups and how it affects them. But apparently white males get intra-abdominal infections more than others. So it's okay. It's also funded by Tetraphase, which honestly isn't a weakness because a lot of these companies that are developing antibiotics, they don't make any money on them. You hear cases of antibiotic companies going bankrupt and the drug never comes to market because they couldn't get anybody to use it because it's either more expensive or people aren't up for trying new medications. And so it's really a shame that that's how it works in real life. So author's conclusion, I agree with them. IV ribociclib is found to be non-inferior to ertapenem in complicated intra-abdominal infections. I hope you like my scale there, putting Xerava as equal to ertapenem. Ignite 4 is called Results of a Phase 3 Randomized Multicenter Prospective Trial of Ribociclib versus Meropenem in the Treatment of Complicated Intra-Abdominal Infections. This was essentially the exact same study design. They were doing safety and efficacy, but instead of ertapenem, it's meropenem. Test of cure follow-up visits were the same. They had less patients this time. Instead of 541, they only had 500. Half received ribociclib 1 mg per kg Q12, half received meropenem 1 gram Q8, and they had the same requirement, it had to be at least 4 dosing cycles, or 4 days of dosing cycles. This geographic region here, actually, if I go back, they had 65 clinical sites here instead of 66. But geographical region wise, it's interesting that not much of the percentage of patients came from the United States. They're mostly from Europe, which honestly, I thought that was a good idea if that was intentional, because we see those higher resistance rates for carbapenems there. And so really you could get a more real world look at how effective ribociclib is. Inclusion criteria was exactly the same. Exclusion criteria was exactly the same, except for the appendicitis. They didn't limit it to 30%. And so they had over 40% for both treatment arms. Definitions for secondary outcomes were the same. And one different thing in their assessment is, instead of having a 10% non-inferiority margin, they chose the standard for the EMA, which is 12.5%. I don't necessarily agree with that. I think if you keep it tighter, it really shows, demonstrates how effective the drug really is. But I guess the FDA agreed to go with 12.5 because that's the standard for the EMA, and they already showed that they were effective against ertapenem. And as far as determination of how many participants they needed in order to have 80% power, they realized they only needed 466 participants. Efficacy-wise, same thing. You've got the orange underline here, where if it's less than negative 12.5%, it showed non-inferiority. So they were able to show that ribociclib is non-inferior to meropenem for the treatment of complicated intra-abdominal infections. As far as safety goes, they had less deaths this time. Same thing, none were considered related to drug therapy. Nausea, vomiting, injection site reactions, and diarrhea were significantly higher in ribociclib compared to meropenem. So that goes along the lines of what we saw in IGNITE 1. And so those are expected things to see. One interesting thing that they had, though, is they had very high cure rates of Pseudomonas. You can see down here, ribociclib cured 94% of Pseudomonas infections. And this is interesting because ribociclib doesn't have any activity against Pseudomonas. They don't claim that it has any activity, but it shows that it cured it. And so the researchers acknowledge this, and there's many other antibacterial studies that have been done that actually have similar results where Pseudomonas is cured. And so the reasoning behind that is they think that when Pseudomonas occurs, it occurs with other infections, and there's almost like a synergistic effect that happens. And when you cure the other bacteria, it disrupts that synergy. And so Pseudomonas doesn't flourish anymore. So meropenem has activity against Pseudomonas, and so that result of 90% there would be warranted. But ribociclib, the authors were smart to acknowledge that and not try to claim that it treats Pseudomonas. They saw in their isotypes when they looked at the data, and specifically what genetic resistance they were encountering. There was a high variety of ESBL enzyme types and carbapenem resistant Enterobacteriaceae. However, they didn't see any carbapenem producing or carbapenemase producing pathogens in the ribociclib arm. They did in meropenem, but unfortunately couldn't make any sort of comparison to say that ribociclib was not inferior for carbapenemase producing bacteria. As far as strengths and weaknesses go, strengths, it had a broad patient recruitment at 65 sites in 11 different countries. I'm glad that they admitted that it doesn't treat Pseudomonas, and that other antibacterial studies show the same phenomenon. Again, they documented the organ of origin rather than only the presence of an abscess or peritonitis. They excluded patients with rapidly fatal illness or septic shock. Weaknesses, they use the same demographics as the Ignite-1 trial. And although it's good to look at Eastern Europe, it also would have been good, since it's almost the same trial with almost the same drugs, to have chosen different clinical sites to see if there's any variance and change there. I didn't really like the larger non-inferiority margin, just because I think if you keep it lower, you show the true potential of what you're looking for. They also didn't limit the percentage of patients with appendicitis. So that's fine when you're comparing it against meropenem, but if you were to use this study to compare against Avucaz, for example, you want to make sure that you're not treating a lot of highly curable appendicitis. There were also no carbapenem producing pathogens in the eravacycline treatment arm, and so we can't make any conclusions about that. And then also potentially an issue being funded by tetraphase, but I didn't see any sway of opinion just because it was funded by them. Authors' inclusions, again, I agree with them that IV ribociclib is not inferior to meropenem in treating complicated infections, and that goes for ESBLs and CRE, but not the carbapenemase producing ones. And they also kind of brought in the sibling to ribociclib, which is tigecycline, and they discussed that even though ribociclib has higher nausea, vomiting, and diarrhea than carbapenems, it's still significantly lower than tigecycline. Almost 5 times more nausea in the tigecycline groups. And they also concluded that you should choose an appropriate therapy for Pseudomonas. Place in therapy. Okay, so this one, I built this table. Took me forever, so I hope you appreciate it. This is looking at all of the competitors to Xerava, other than Zerbaxa, and I realized that afterwards, and there's just too much time to include that one in there since I hand did all the math, and all of my prices come from McKesson. One thing to keep in mind here, so Xerava is $50 for each vial, and that is a set cost. It's based off mg per kg. And when you look at generic tigecycline, you're like, oh, that one's great. We should go with tigecycline instead of Xerava. Well, one, it has the all-cause black box warning. Ribociclib does not. And from my understanding, a lot of hospitals, instead of dosing it 100 loading dose and 50 maintenance dose Q12, lots of times they'll do 100 Q12, and so that inflates the price. I can't speak to that, and so I didn't include that so that I could be as accurate as possible. But that would actually change the price to $524. When you're looking at this combination therapy, average daily cost of $55, that looks really great. A lot of times when patients are in the hospital, our main goal is to get them out of the hospital. One way you can do that is to put them in an office suite or home infusion therapy. And when you do that, let's say the patient leaves the hospital, they go home, they have a nurse come and visit them to help them administer these medications. Well, you now have nursing visit costs, nursing teach costs. You've got, that's 3 times a day because all of those are Q8. You also have the horrendous Vanco monitoring that nobody likes to deal with. And so that also drives the price up. And so there's a lot of variables that I couldn't include in here. I just did straight drug prices. Another benefit here to being at this lower price point is Xerava is a monotherapy. So this covers everything that all of these other medications do. The only thing it really doesn't cover is Pseudomonas. And the direct competitors to Xerava right now, just so that you're aware of, is Vabomere and Avycaz. And Avycaz, actually, they still recommend to give with meropenem, so that increases the price more, but those are $1,000 a day. So when you see ribociclib at $150+ a day, that's pretty impressive. Place in therapy for stewardship. There's obviously a need for alternative agents in a world where organisms are becoming increasingly resistant to carbapenems. The in vitro data results demonstrate that there's a dominant activity compared with similar agents. Potentially this could lead to shorter duration therapies because of its potency. We don't know that yet though. There's a decreased side effect profile, and that's in direct comparison to tigecycline. There is more nausea, of course, than the carbapenems, but having no black box warning and less nausea, vomiting, diarrhea than tigecycline if carbapenems have too much resistance. And cost-wise, $150 a day is pretty impressive compared to many of the ones that are $1,000 or more. C. diff is another major point I'm trying to drive here. And if you look at this table, you can see cephalosporins, carbapenems, and their odds ratios for inducing C. diff within 60 days of admission to a hospital. I've personally seen data showing rates of 30% C. diff in some hospitals. And unfortunately, a lot of the drugs that you use for really scary diseases and infections end up turning into C. diff. Ribociclib results indicate that there's no induction as well as activity against C. diff, and that's from that poster from Kevin Gary. And by treating C. diff and it not occurring in patients during hospitalization or afterwards reduces rehospitalizations. This data, by the way, comes from a journal published in 2020 by the American Society for Microbiology. So in conclusion, with the evidence that I have given, ribociclib is non-inferior to carbapenems in treating complicated intra-abdominal infections. It shows real-world success combating bacteria designed as urgent threats according to the CDC and WHO. It has potent activity against carbapenem-resistant phenotypes. It shows promising outcomes in treatment of C. diff. It's more patient-friendly than tigecycline in regards to the black box warning and side effect profile. And ribociclib is not recommended for Pseudomonas. For future action, I think hospitals should be encouraged to add Xerava to formulary. I think this creates more revenue for the pharmaceutical company, who is the antibiotic ones are hurting for money for development of these drugs compared to, you know, regular drugs that go out on the market that everybody recognizes as a bad reputation. I think we should initiate more research exploring ribociclib potential to treat C. diff infection and prevent induction, and then fund another trial to expand indication to bloodstream infections and complicated UTI. I think that because of the in vitro data, I think it would be very beneficial to know if you can treat bloodstream infections and have that indication. So for discussion, I decided to create a case study. So pay attention to this one. I think this is a pretty fun case to look at. So this is FB. He's a 57-year-old male, presents with a fever, complains of painful, frequent urination. He is, we'll say he's a nursing home resident. He receives catheter irrigation of gentamicin for UTI prevention. And this is something that's given nightly on an empty bladder. He's had flank pain for a couple days, chills with that fever. He's a type 2 diabetic patient. He's had 3 UTIs, the first one being in April 2020. He's allergic to penicillin and sulfa. local demographics show that there's over 35% resistance to fluoroquinolones. Cultures are positive for E. coli, Kleb species, and Enterococcus species, and we're gonna make the diagnosis of pyelonephritis. So I really tailored this. So what medication would you choose? And I'll let somebody give an answer or ask a question on this, but your options are fosfomycin 3 grams once, levofloxacin 750 for 7 days, macrobid for 7 days, ceftriaxone IV, probably not as a push, probably do it over like 30 minutes, and then eravacycline 200 milligrams orally for 7 days. What are you guys' thoughts?
Hey Zach, can you hear me?
Yeah, Zach, I hear you.
It's good to hear from you. This is Zach. I think based on the presentation, you kind of steered us in the direction of Xerava being the best choice of the 5 that you have listed over on the right.
Yeah, well, and I was hoping you'd say ceftriaxone. I think a lot of people would probably shoot for that, but it doesn't have any coverage for Enterococcus. And I'm going to kind of go through these options here and just kind of see. But fosfomycin, I don't know, maybe you could use that one. I don't know enough about that. If anybody has any thoughts on that, shoot, but probably would want to use it IV instead of orally. Levofloxacin, obviously you're not going to use that one because of the resistance rates. Macrobid, you're not going to use that for pyelo. Ravacycline, so this way I decided to do a UTIs because I believe the Ignite 2 trial, ravacycline failed to show efficacy for treating UTIs. It was very successful in treating in IV. I couldn't get a whole lot of data on this, so that's why it wasn't one of my trials that I discussed. But when they transitioned from IV to PO, that's when it failed. And so they couldn't say that orally ravacycline worked. But one thing that they didn't do is they didn't restrict any diet. And so tetracyclines, as we know, are going to be have issues with, calcium and milk, dairy products. And so if they didn't control for any diet and restrict a couple hours before or a couple hours after taking the medication, you're obviously not going to see the results. And so I think the drug company kind of put themselves in a bad position for that. So I think we should have more studies in the future looking at that because I think it could be a good option. And that concludes my presentation. And I am up for any questions you may have.
Hey, Zach, this
Hey,
is
Dr.
Roger.
Hefner.
Yeah, back to your first study that they compared to ertapenem.
Yeah.
So what was the clinical cure rates of ertapenem compared to ervacycline?
Let me go back to that study here. Okay, so the cure rates. So you're asking what the percent of cure rate for
Yes.
eravacycline compared to ertapenem?
Yes.
Yeah, so you're gonna see so the main one that they highlight in their studies was this micro intent to treat population, and eravacycline had 86.8%. Ertapenem was better at 87.6%. Yeah, that's a really good question. I'm glad you asked that because I definitely breezed through that one. But yeah, so ravacycline showed to be a slightly less percentage efficacy than ertapenem.
But they were doing a non-inferiority study anyway, weren't they?
Correct.
Okay. Another question too, I wrote this down and then you kind of addressed it as well. Tell me a little bit about the inclusion or the exclusion of the appendicitis patients for intra-abdominal infections. So what's going on there? Why has that become so vogue to look at?
Yeah, so why, your question is why did they choose to limit the appendicitis?
Yes.
Yeah, that one I thought was pretty interesting, and I didn't really delve too much into what I guess the infection of the appendicitis was, like what was causing that, but apparently uh, the appendicitis is very easy to cure. It's very highly curable, and so if
With
they
what?
have with eravacycline and ertapenem.
Or
You mean other antibiotics? Sorry, I think you cut out.
no, I just stopped saying things. I was letting you answer the question.
Oh, so yeah, so eravacycline, ertapenem, penicillin. There's it just they decided that it would skew the results of making it seem like eravacycline was more efficacious in intra-abdominal infections if they had appendicitis. A high
And again,
percent.
I'll open up the question to the entire class. So what has been discovered in the relatively short time period about how we treat appendicitis? Zach Kim, I see your name, but not your face, right below Zach Blanchard. So
So you're shipping the question to me, Dr. Eckler?
I'll ship it to anybody in the, because it's clinically changing and happening right now. And Zach Blanchard has identified that they were included or excluded in these intra-abdominal studies because of the appendicitis. So my question for the crowd is, why are they doing that? What have we found out about appendicitis in the last few years?
So I don't know if I have the correct answer for you, but I feel like it might be something that we can treat surgically without any sort of antibiotics, potentially, if you catch it soon enough. I don't know if that's what you're getting at.
If you flip that around exactly, then you would have the correct answer. So the most recent data is that if you get antibiotics into somebody who's having an acute appendicitis, they don't require surgery. So it's completely shifting gear of treating aggressively if they think they're having appendicitis symptoms. So it's very antibiotic responsive. Why did your second study throw in that less nausea and vomiting than the tigecycline?
Yeah. So that was I don't know, I guess you could throw in that because it was funded by Tetraphase, that's why they threw that in there, because there really was no other mention of tigecycline in the study. So why did they include it? It seemed like a fairly marketing thing, but I think they were trying to save face with it being higher rates than meropenem.
Yeah, seems like a very odd thing to allow to be actually published.
Yeah, I
Oh,
know.
Diet Coke versus Diet Real Coke, but yeah, more people like us than Pepsi. What? Okay, that's all I have. That's not true. If Kathy's not going to ask any questions, I have one more. Do you get significant lung penetration? Are you going to be able to treat pneumonias with this antibiotic?
That one I can't speak to that. I know that omadacycline is currently indicated for that, and but it's not indicated for intra-abdominal infection. So I don't have any data. I can't speak to that at all. It'd be a good future study though.
I was just curious if you came across anything in the kinetic data or anything anywhere. So
no.
Okay, thank you.
Yep.
I don't have any questions.
Easy enough.
I have a question. So you mentioned C. diff at the beginning. So would you choose rivacycline over fidaxomicin for the treatment of C. diff? If so, why?
So yeah, so would I pick ribociclib over fidaxomicin? Uh, this study is very impressive. I mean, of course, it's in vitro, so we don't know how it's gonna work in real life, but I would stick with fidaxomicin right now. We know it works, but I'm very inclined to go with ribociclib.
Thank you.
And are you sure your prices are correct?
What do you
sure
have
you
a
didn't-
question about?
Did you price out like, the yen versus dollars or what? I can't imagine that this antibiotic's going to come out this inexpensive.
Yeah, no, it is. Yeah, I think it's also on like 340B program as well. But yeah, no, it's $49 a vial, and each vial is 100 milligrams, I believe. So yeah, no, it's super cheap. I think when it first came out, it was a lot more expensive, but it's dropped significantly, and I think it's going to go up a little bit here in this year, but it's not going to be much. It's going to be like maybe $50 extra daily cost.
I have a little trouble with, concentrations versus doses. So I'd have to refer to John Roberts to help me make sure that those prices are correct.
I do have a supplemental Excel spreadsheet I can give you too.
Okay, any other questions for Zach? Okay, we're out of time. Let's go ahead and take a 10-minute break and then come back for the second one for today. So good job, Zach. So thank you for the time and effort that you put into this.
Thank you.
So let's come back in 10 minutes.